there is a profound, both psychological and physical impact to the health and vitality of people who get this disease. And I don't know that always family members even understand that. And sometimes a lot of my patients even feel guilty for, the extra time or other things that, that go along with this disease. And you really shouldn't, because it's certainly something that is quite debilitating. It's also highly associated with Graves' disease, and Dr. Litchfield is going to answer some questions and talk about that in much more detail than I could ever. But 80% of people develop thyroid eye disease within a year and a half of their Graves' disease diagnosis. And that's an important point, because a lot of patients ask me, say, well, what are my chances of getting thyroid eye disease? Well, it depends upon when you were diagnosed a little bit. There's about a 25 to 30% chance of getting it with Graves' disease of some form, or mild to moderate, etc. But if you had Graves' disease for several years, the chances of you getting thyroid eye disease are actually much lower and much smaller. And so it is a time-dependent process. It also impacts women at a much higher rate than men, reported anywhere from 5 to 9 times for women. And we do see a lot of women, obviously, in this group today affected. The men who are affected tend to be affected much more severely and often lose vision. And so it's always good that if you find someone who has thyroid eye disease and they're a man, a lot of times they have a very serious problem and often require urgent intervention to save their vision. Now, thyroid eye disease comes in many different flavors, and I see it a lot in different types. I want to show you some pictures. But commonly we've defined it as eye bulging or proptosis, eyelid retraction, which everyone knows when they try to take a photo of how they don't like their photos and their eyes are staring, so to speak. Double vision, which is probably the most debilitating of all the things. You can't drive, can't work very easily. We'll learn a little bit more about that. But also the inflammation that's associated. About 70 to 75% of patients have a lot of inflammation, meaning a quarter of them don't. They just have this silent progressive disease that's hard to diagnose. But the majority, about 75%, do have this inflammatory process that's ongoing. And so, as you can see, this heterogeneity builds in already a lot of confusion just in the diagnosis, and we haven't even gotten to the treatment part yet. Now, it's commonly associated with Graves' disease, but thyroid eye disease is a distinct disease. The immune system, those cells from your bone marrow, attack 2 receptors. One is primarily on your thyroid, called the TSH receptor, and antibody testing and things like that. The other receptor is primarily on the tissue around the eyes. It's an IGF-1 receptor. We don't need to remember that. But 2 different receptors. That's why you get in these 2 different locations. And the diseases tend to go in their 2 different courses. Still, treating the thyroid doesn't necessarily help or hinder the eye disease, except for some very important exceptions. And vice versa, treating the eye disease really has no impact on treating the thyroid. So we do have to work together in treating these very different causes but associated processes. And you all know that there's disfigurement involved in the sight-threatening complications. It's not just double vision, but the muscles can get so enlarged in this disease from being attacked from the tissue behind the eye that they actually squeeze the optic nerve and cause you to lose vision. And as I said, this is a very heterogeneous disease. These are all examples of my patients, and they all look very, very different. And they've all had very different courses. Several of these patients are losing vision, and I've had to do emergency surgery on them. Some of these patients, you might say, I don't really even notice a big difference, right? I mean, it looks pretty quiet and such. But the important point here is that this can look like many different things, and it has to be treated in a very personalized way. I wouldn't treat these patients all the same. I would treat them very differently, and it has to be personalized based upon what risk they pose, what symptoms they're having, and how bad their disease is. So this disease normally follows a course. It gets worse and inflamed and worse over about 6 to 12 months, and then it plateaus. Now, it doesn't mean the disease gets better. It just means that it doesn't get worse. Some symptoms, like the inflammation, can get a little bit better. the disease doesn't get better, but it begins to stabilize. And when it stabilizes, it actually then, the symptoms don't go away, but they at least don't get worse. Now, this is kind of reassuring, but it's kind of not, right? Because it doesn't get worse, but that doesn't mean it goes away without treatment or without some type of intervention. And that treatment can be very supportive type of things like eye drops. They can be surgery, or they can be even much more significant processes that include medication. Sorry, just trying to pry the grips of steel in this thing. All right. So this is an example of a patient once they get to that chronic phase of what can be done with surgery. And surgery now is done in both eyes, at least I do it, both eyes at the same time. Typically about 90% of my patients, one surgery. And both patients are very different patients, but they had different problems. The patient on your left had mostly just eye bulging. And we were able just, with a decompression, one surgery, to move her eyes back into good position. Based on the right, you might say, well, does she really have bad thyroid eye disease? Well, if you saw her before picture, you would. Now, she doesn't have terrible bulging, but she has all this surrounding swelling, etc., around her eyes. And so we did a variety of things, including taking away a little skin and moving her eyes back with a decompression. The details aren't as important. It's important to know that there are options no matter what the disease is. The other thing that I'm going to present is a real-world case. Now, this is hypothetically speaking, of course. A nurse with new onset double vision had Graves' disease and was very well controlled, but with worsening eye disease and was very asymmetric. Now, this was a person who's very highly functioning, and has a very important role in healthcare as a nurse and taking care of people every single day. And you can imagine how it is trying to read the vials of a medication when you're seeing two of them, and how that is worse. So, this is of course Jeannie, who's going to talk a little bit later today. But Jeannie had teprotumumab, the alternate option for treatment, and we'll talk about the pros and cons of this. It's not a perfect drug, but certainly has changed the way we treat things. And had 8 infusions, and has gone and had a remarkable result. And I'm going to let her fill in the rest of the story in a little bit as we go through. So that is just the introduction. And so, I do want to welcome individually Dr. Litchfield, who we're going to have a lot of discussion and hopefully have lots of questions on the endocrinology aspects of this disease. I know that can be very confusing, and how it impacts with the eyes, doesn't impact with the eyes, how you deal with it. Karen Mullen, our Director of Care Coordination and Finance, is going to talk about the practical aspects of affording care, what's covered, how you can make sure that insurance covers your care, what can be done, etc. There's amazing opportunities that often go undiscovered, and that we can really help to overcome some of those barriers. Dr. Gupta is going to be our moderator, in addition to, she also does all these surgeries also, in addition to runs our research program. So she's going to moderate and keep us in line. And then you're going to hear a little bit later about Jeannie's journey through with thyroid eye disease. So thank you all for attending, and we'll get rolling with some of the aspects.
Thank you so much, and again, welcome to everyone who's here in person and also virtually. One of the first topics we're going to talk about is identifying thyroid eye disease. And I'd like to reach out to Dr. Douglas and Dr. Litchfield and just ask, what are some of the hallmark symptoms that you encounter for patients with thyroid eye disease? But I'd also like to know, what are some of the more subtle symptoms that perhaps get overlooked by people who are not as familiar with diagnosing it, that you tend to encounter, that are kind of things that clue you in to thyroid eye disease being a potential diagnosis, because as we all know, I'm sure as patients you know, sometimes it's frustrating. You've seen many physicians or many providers, but your eye disease and symptoms haven't been diagnosed yet. Sometimes it's confusing because there's a lot of overlap with other diseases, so we'd love to know your experience on making the diagnosis.
Dr. Litchfield, you see them first, so I'm gonna let you go first.
All right, thank you. Well, most of the time we see patients with thyroid eye disease in the context of having thyroid disease as well, usually hyperthyroidism. What I will usually start with is just kind of a very general question and ask my patients, are you having any problems with your eyes? Something very general, because quite honestly, the spectrum of trouble that you can see ranges quite very widely. You know, it can go from a bulging eye that everybody can recognize immediately to more subtle things such as excessive tearing or dryness of their eyes or inflammation or pain or redness. And so trying to keep it general allows the patient to report what they're experiencing and will allow me to kind of dissect that further. So soft tissue inflammation is very common, and it may not be associated with that classic bulging look. Typically, we'll be able to see or recognize pretty quickly if the patient's eyes are asymmetric or are proptotic as well. Anything you'd like to add, Dr. Douglas?
Sure. So a lot of my patients come in suspecting thyroid eye disease, so I'm already thinking about it quite strongly. The eyelids are usually the giveaway for me, especially the flare. That typical lateral lift of the eyelid where it looks like a little bit of a stare. You don't get that with almost any other disease. The other thing is I look at old photographs, driver's license or some photographs that they've sent in, and that will be very, very helpful looking for that change in appearance over time, and that helps to clue things in.
Wonderful. Thank you both. One housekeeping thing I forgot to mention at the beginning is there are some blank cards in the center of your table. We'd love to learn how you found out about this support group and session, because that will only help us planning events moving forward. Also, we're here to support you. So at the end, I will open up the floor for any questions. So please write down or think about what questions you may have as we're talking. We'd love to be able to answer them for you while you're here. Moving on to the next question. How do you, Dr. Litchfield, diagnose a patient with thyroid eye disease? As you mentioned, or as Dr. Douglas mentioned, you're kind of on the front line because you're seeing a lot of patients who have underlying thyroid conditions. So any specific testing you do, or we'd love to know your...
Right. So you don't need to have a problem with your thyroid function to have thyroid eye disease. Now, most patients do, but it is a clinical diagnosis. There's not a blood test that will tell me that you have it. So usually it's a combination of me taking a patient's history, talking about their symptoms, and then examining the patient and looking for those telltale clues that will indicate that something wrong is going on in the eyes. Now, other things can be very helpful. We can use CT imaging or a CAT scan or an MRI as well, and that allows us to look on the inside and see if those muscles are swollen or if the tissues around the eye are inflamed. And the MRI will also allow us to kind of assess the fat and what's happening in the fat in the orbit of the eye as well. But usually we start with measuring thyroid function, of course. If you see hyperthyroidism, that's a really telltale clue, specifically Graves' hyperthyroidism, but I've seen it in patients that have no thyroid disease at all, or Hashimoto's disease. Typically not so much multinodular thyroid disease, but usually autoimmune thyroid disease is going to be there in most cases.
Wonderful, thank you. Dr. Douglas, we have a few more specific tools at our disposal in terms of examining patients with thyroid eye disease to measure how much their eyes are bulging, but is there any other testing that you incorporate when you are evaluating a patient for thyroid eye disease?
Yeah, so there's lots of little technical things you can do, but the biggest and the most helpful thing I do for my examination is typically just talking to the patient, and while I'm talking to them, they're relaxed. You know, I'm not coming at them with my, her towel or, and making them wince or anything else like that. But I'm watching how they blink, how they move their eyes, how swollen the tissue is. Everything like that starts to add up, and looking for asymmetries, etc. And then going back and looking at old photos. Then the specific tests are actually measuring how prominent your eyes are, or looking and measuring how dry they are, and things like that. But honestly, just as Dr. Litchfield said, this is a clinical diagnosis, and looking at those changes, and it's so heterogeneous. Some patients don't have any inflammation, some have terrible inflammation. So always thinking about what it could be, and what it is not. So one thing just to point out is that not everything is thyroid eye disease in my world. Sometimes there's a tumor behind the eye. And so there are other things that I'm just looking for clues of why this may not be thyroid eye disease, and why I may want to order an expensive test, or I may not. So those are just clues, but they all come from just honestly just sitting and having a little conversation while taking the history, and that's what I'm doing most of my exam.
Great, thank you. And I would tend to agree. Eye bulging is the most common cause of eye bulging in an adult is thyroid eye disease, but that's not always the case. So in the back of our minds, we're always trying to make sure we're not missing something else. And the imaging, as Dr. Litchfield mentioned, is helpful not only to see the enlargement of the eye muscles for thyroid eye disease, but actually to exclude other potential conditions that might be causing eye bulging that are unrelated. Once you do identify that a patient has thyroid eye disease, what are the next steps? Because as we know, and as I mentioned, sometimes patients have seen many physicians, they may have symptoms that aren't quite typical or very severe, don't get a diagnosis. So that's a huge step for a lot of patients, is just having a diagnosis attached to the symptoms that they've been having for a long time. But once you make the diagnosis, what are your next steps?
So my primary job as an endocrinologist is to help manage the thyroid, and it's usually hyperthyroidism. If a patient's hyperthyroidism is not well controlled, I think their thyroid eye disease is going to be harder to manage as well. That's kind of my first step. There are different ways that we treat hyperthyroidism. Most of the time, we're starting with medications, most typically methimazole, and we'll use that drug to settle down the hyperthyroidism. Other treatment options for hyperthyroidism do exist. In some cases, we'll use radioactive iodine. I tend to try and stay away from radioactive iodine in a patient with thyroid eye disease, because there is a tendency for that radioactive iodine to cause the thyroid eye disease to flare. In cases where we can't control hyperthyroidism with medications such as methimazole, we will consider doing surgery to remove the thyroid. I think secondary issues are also important to consider. Smoking cessation. There's definitely between smoking and thyroid eye disease happening, and also for that smoking to make it worse. So smoking cessation is a big part of what we try to emphasize. There are some data suggesting that supplemental selenium can also make a difference in settling down thyroid eye disease. It's probably not a cure, but it's something that can help. I think if patients have vitamin D deficiency, that's an issue that we can also readily remedy in my office. Now, usually if a patient has meaningful thyroid eye disease, though, I'm going to involve somebody who's expert in the care of that problem. And I can't tell you how many times I've seen patients with obvious thyroid eye disease who have seen other clinicians, their primary care doctor or an optometrist or even an ophthalmologist, and that just doesn't get identified. And so they're not getting access to the care that they need. And so usually we will quickly involve an oculoplastic surgeon, someone who has a lot of expertise in managing patients with thyroid eye disease.
Wonderful. And Dr. Douglas, we'd love to hear what your next steps are once you diagnose a patient with thyroid eye disease.
Yeah, so once we establish the diagnosis, then it's a realistic discussion based upon how severe the disease is and where they are on this journey. So if they've, we can deduce that they've had thyroid eye disease for 10 years and they've really not had any symptoms, our supportive care such as eye drops, dry eye treatment, etc., might be plenty. But if they have much more severe disease, or is it vision-threatening disease, then the treatment has to increase to meet the severity of the disease. And that's when early in the disease process we start talking about medical therapy. As long as it's not an acute emergency, we would typically reserve surgical therapy only after the disease inflammation has kind of calmed down and they've reached a stable point of the disease. But each of those are graded based upon how severe the disease is. If it's vision threatening, and depending upon other things, we really do have to take action. And that can be medical or it could be surgical. And I present both options to my patients. And sometimes it's a combination of both, frankly. It just depends upon the stage. And both have their pros and they both have their cons. There's no perfect cure, but together they do offer a reasonable amount of significant improvement for most patients. But it's a very personalized discussion based upon the severity, the risk of each of these treatments based upon age and other factors dealing with the side effects of these medications and surgery. So that's usually the balance in which we're having a very personal discussion about a treatment plan moving forward.
Thank you. So moving now, you were getting into talking about treatment options for patients, and some of you may have been recently diagnosed with the disease. Some of you may have been living with it for a long time and may be aware that the treatment landscape has changed pretty dramatically since 2020 with the approval of the first ever drug to specifically treat this disease. So we're going to move on to the treatment options. And Dr. Litchfield, historically, how have you treated your patients who have thyroid eye disease or co-managed them with other specialists?
Well, it's an interesting question, and quite honestly, things have changed over the last 5 years a lot. I think thyroid eye disease has always been a fairly common element of patients with especially Graves' disease, and for many years, the treatments we had were very heavy-handed treatments. And so in many cases, we would sit with a patient, we would manage their hyperthyroidism and try and control that. And in many cases, the patients would just have to live with it, right? Unless they had such severe disease that there was a big emergency, an impending emergency, we would say, oh, this is part of having hyperthyroidism, and you can see your eye doctor for some eye drops or symptom control, but I wasn't going to give them high doses of steroids, and they weren't sick enough to have an operation, and so they just lived with it. Over the years, many things have been tried to treat these patients. Managing the hyperthyroidism does help to a degree, but it's not enough. We would refer a patient for eye drops or gels or in some cases, plugs to be put in their eyes to help with the dry eye and so forth. In more severe cases, I've seen very rarely that we will use radiation to the orbit. Now that's a very dangerous type of treatment, and it can in and of itself be threatening to vision. More frequently, we would use high doses of steroids, but these are very high doses of steroids, enough to make your immune system suppress and associated with all kinds of other serious medical problems. And then, again, in those more extreme cases, we would refer our patients for operations.
Now, Dr. Douglas, what recent advancements have changed how you manage your patients with thyroid eye disease?
Yeah, so just kind of picking up where Dr. Litchfield was talking about, with the high-dose steroids. As an oculoplastic surgeon, I was never really comfortable prescribing high-dose steroids because they can get patients into trouble very, very quickly. In fact, one of the largest studies that was done using high-dose steroids out of Europe, two out of about 150 of those patients, 2 of those patients died during the high-dose steroids from a hepatotoxicity. So there are risks to treatment. So I think I agree exactly. You have to match, like, well, this disease is bad, but the treatment is also pretty tough too. In 2020, there was a drug that came out, it's called Tepezza or teprotumumab, and it blocks one of those receptors, the IGF-1 receptor around the eye, and it causes the tissues to regress. So instead of having your thermostat turned up really high and your immune system and these cells churning over and causing all this activity, it kind of blunts that, kind of turns it back, turns these cells and resets them back to normal, and they shrink. Now, there's some really great things about teprotumumab. It works in about 80% of people. It causes a dramatic improvement in many of those people, a very significant improvement. It's the first medicine ever approved for that. In fact, the FDA gave it fast track approval because it was so effective. Now, there's also, as with any medication, another side of, well, you probably can't use it on everyone, and what are the risks of this medication? The risks, because it's so new, one is that there's some muscle spasms and some weakness and even some hair loss. Those are usually pretty well controlled and all bounce back. And patients usually don't complain too much about that. But there was also hyperglycemia, not quite as severe as with the high-dose steroids, but sometimes it would sneak up on patients with some borderline hemoglobin A1Cs who weren't controlled and have some spikes. So definitely had to have co-management there. And then hearing issues that have been much more popularized and talked about. And that was very new. We saw a couple cases of that in the initial study, but what we found since then is that patients who have hearing issues may experience a further decline in their hearing, or patients who have no hearing issues at baseline typically are okay. And they have to be followed very, very carefully, like every other visit or so, doing audiology, making sure that there are no declines. And that has significantly helped that issue. The other thing is that you might have to use this drug again. About 75% of people, it's a one-time thing where you just do 8 infusions and you're done. But about 25% get a reactivation or flare. So we're on the early end of this. Of really beginning to understand what this drug can and can't do. I liken it to, I gave one of my first presentations in immunology when gold was still being used for rheumatoid arthritis. And then Humira came out, and now rheumatoid arthritis has dramatically changed. You don't see people having joint replacements for rheumatoid arthritis, but that was one of the mainstays of treatment, was joint replacement for rheumatoid arthritis. It doesn't cure the disease, it just gives you a new joint to be destroyed. And that's probably the early stages in which we are with teprotumumab and future drugs coming out and us refining and really learning the nuances of this drug.
Thank you, and I'd love to put that up to Dr. Litchfield too, to understand how recent advancements have changed how you manage, treat, recommend therapies to patients.
Yeah, so as I said, for many years, we were having patients live with mild to moderate symptoms, and those patients now have an option that has really been a remarkable improvement in how we offer a more complete solution to the autoimmune disease that we're dealing with. And so we've sent many patients for this treatment and seen really effective, or really remarkable results. I'd say over 80% of the patients are showing some improvement. Most of them get by with a single course of therapy. Some patients have required more than one treatment course. But in the contrast to 10 or 15 years ago, where we were telling patients to kind of suck it up and live with this, we now have an option for patients that are having these symptoms. And we are, we're offering them something in between the suck it up and live with it to you need to have an operation on your eyeball or on your eye socket, so that it's really nice to have something in between those. That's not to say we don't still send patients for surgery. I wish this medicine was a panacea that absolutely cured everything, but it definitely, I think, has decreased the number of patients that we have to send in for surgical therapy, and I don't remember the last time that I gave a person high doses of steroids to treat this.
Wonderful, thank you. It's clearly been such a game changer in this field, and we're in the early stages because it's the first drug that is out to treat a condition that previously had no cure. So there will be, I'm sure, many advancements to come, but thank you for sharing your experience and how this, in the short 5 years, has changed your practice. Shirwa, I'd like to transition a little bit to speak about the financial hurdles and aspects of the disease, which are just as important to patients as the disease itself. And we're very lucky to have Karen Mullen on our team, who has such a breadth and wealth of knowledge in this field, and happy that she's here to be able to share her expertise with all of you. One question to ask Karen first is, what are high-cost biologics, and do most insurances cover them?
Thank you, Dr. Gupta. Thank you, Dr. Gupta. Pleasure to be here, everyone. We're lucky that since launch of Tepezza, there are a lot of our insurance policies nowadays that are covering Tepezza. Most of the time I'm seeing catastrophic policies, self-funded policies, and HMO policies are some of the policy types that don't cover Tepezza, but for the most part, commercially insured patients as well as Medicare patients, we're having great success with getting authorizations and access to care and treatment for Tepezza.
Wonderful. How long does it typically take to obtain a prior authorization for Tepezza? We're talking real-world experience, but perhaps also in your practice.
Initially at launch, when the J-code was called an unclassified code, it was approved by the FDA, but it didn't have a permanent classification code attached to it. It was a little more challenging, but now in the last 4 years, it's been pretty easy to get prior authorization for. So it can take, we've been successful in getting an authorization turned around in 2 or 3 hours, up to 1 to 7 days. And that's just first line therapy, first time patient is receiving Tepezza, first course. But it could be a little bit more challenging on retreatment. I'm seeing, anywhere from 30 to 45 days on retreatment. But depending on how we submit the prior authorization and how crafty we are at that letter of prior auth request, we can turn around those pretty well too, pretty quickly.
That's wonderful. What happens, and I think this is really important because we know the treatment course can sometimes take a while. What happens if a patient changes insurance mid-treatment? Maybe they change jobs or something, and a life event happens. How does that affect their ability to continue getting drug?
Actually, it's pretty easy to get prior authorization on a patient that has changed insurances mid-course of treatment. The thing that we look for is maybe having a discussion with the patient and them alerting us to, I'm about to change my policy. Then I go in and have a conversation with them about what policy type are you going to select. Because that is the key part here, is making sure they have a benefit that will cover them under the next policy. But we argue very vigorously on if you're changing mid-treatment, we'll submit a prior authorization and treat it as a continuum of care, as opposed to a whole new treatment course. And so once we say continuum of care, the utilization management department now has to justify taking the patient off of treatment, which they don't want to do. They're very reluctant to taking a patient off mid-course. So we're pretty successful on keeping them on treatment and keeping the same treatment course going and not really experiencing an interruption of care at all.
Great. Now, if a patient's insurance does deny coverage to Tepezza, what are patients' options?
Yeah, that gets a little challenging, especially during second course, third course of treatment. But definitely some good options out there available. So we will go and appeal first level appeal, second level appeal. Then it goes to independent medical review boards. And then after that, it'll go to Department of Labor or Insurance Commissioner's Department. We take it all the way up the food chain. And if a patient, for example, none of those methods work, then we can submit to the Amgen, the free drug program or bridge program they call it. Also, foundation programs may be able to supply drug for the patient But that's the key here, is knowing that there's lots of options available to the patient, and we don't stop until, honestly, we access care for patient on using one of those options.
Great. Now the next question is, what programs are in place, because obviously this is a very high cost drug, what programs are in place to cover patients' out-of-pocket costs and related expenses? Because there's probably a lot of apprehension and anxiety around what the burden of treatment may be on the patient themselves.
Yeah, luckily, we have a lot of options available out there now. Manufacturer copay assistance programs have always helped cover the patient's out-of-pocket as well. There's foundation programs available, like I was mentioning earlier. Our Medicare Advantage plans impose an out-of-pocket to the patient, so we always sign up our patients for foundation programs that cover those out-of-pockets as well. And then some of the drug-sponsored programs are really great for getting access to care for our patients.
I think it's so important for patients to be aware of all those programs. What would a patient's out-of-pocket cost be for a Medicare Advantage plan?
That's probably one of the scariest topics that I discuss with patients, is when they have a Medicare Advantage plan, what does my out-of-pocket look like? And so annually this year, 2025, the out-of-pocket cost to a patient is $9,350, and that is on a standard plan. But there's lots of retiree benefits that don't assess the patient any responsibility at all. And so it varies from zero out-of-pocket all the way up to $9,350. But what we do immediately is enroll our patients in the foundation programs, who you have to meet income criteria, but they're pretty generous on what they allow. And those out-of-pockets are covered by these foundation programs. So I'm always trying that first to make sure that, there's this program out there will cover it. Then after that, then we can look at that out-of-pocket for the patient. And in some circumstances, if they meet by, hardship applications, or if they meet, just different programs available that they can't meet, then we'll split up the payments due to them over a 6-month period. But it's important for patients to know, though, that any provider they go to with a Medicare Advantage plan, in or out of network, most times they have an out-of-pocket, and they do understand that. It's just helping them through, accessing care through those foundation programs, so that we can meet their out-of-pockets and help them with that process.
Thank you. We're going to transition a little bit to our last segment here with our wonderful patient who Dr. Douglas has already introduced, Jeannie Twist, an icon for us in the field. I know you've all probably seen her on television, but such a wonderful advocate for patients. We couldn't be more thrilled to have you here. Thank you for giving us your time, all of us. And we do have a couple questions for you. Can you describe the early signs of thyroid eye disease for you and how it eventually escalated to your point of diagnosis?
Yeah, sure. Hi, thank you, and thank you very much for having me. I didn't understand what was going on with my eyes. I'm going to speak primarily to, I think, this table and someone over there. No, these are patients. And, I had some tearing and I had some redness, a little itchy eyes, and that went on for a few months, I have to say, and I didn't really know what was going on. I also, at the very beginning, didn't really know that I was a Graves' disease patient. So they were very subtle, and my eyes didn't change really, and my vision didn't change at that point, but the tearing was odd. I just thought it was maybe adult onset allergies that could happen, and then I kind of blew it off. I didn't think anything of it. I didn't even use eye drops. So the changes that I noticed were so subtle at the very beginning, I really didn't think I had a problem.
Okay. And what was the process to even getting the diagnosis like for you?
That was insane. Because when I did have a problem and it came on fast and furious, with bulging eyes and inflammation, and I had, the stare that people have, and I had one eye stuck in my eye socket, couldn't move. Colors were changing. I could tell that one eye was very, the colors were really bright, the next eye was not so bright. I was closing my eyes to read things, not closing my eyes, one eye to read things, closing one eye to see something else, double vision. Nobody knew what was going on. So I went to my primary care physician, I went to an ophthalmologist, I went to an optometrist, I went to an eye doctor. I went to my endocrinologist. I think I had 6 doctors before I got a diagnosis of thyroid eye disease, and that was a neuro-ophthalmologist who did that. And by that time, I already knew I had thyroid eye disease because I had done my research, and I was at that point thinking, it's great to have a diagnosis. Now I'm not crazy. This is not, just in my head or just in my eyes. So it took a long time. It took about 6 months and 6 doctors.
I'm sure that journey and those symptoms resonate at some point with each of you out there, because I know it can sometimes be frustrating to make it to that place of diagnosis. In your case, we know you are an oncology nurse. What challenges did having thyroid eye disease present in your day-to-day life and work? I know Dr. Douglas touched on it a little bit, but.
Yeah, so with any work, reading was a problem. It was hard to work on the computer. Bright lights, if anybody's been in a medical facility, there's a lot of fluorescent lighting going on, and it was so hard to be anywhere with fluorescent lighting. I'm a night shift nurse, so I was lucky in the sense that I could turn the lights down or turn some of them off, but then I had to deal with the computer, which is very bright, so that was turned down to the lowest setting. I had a lot of double vision, so I would just close one eye and start the IV. But you can imagine that when you have this disease and you saw my picture, it really was quite disfiguring. I come into a patient room, my eyes are tearing, they're red, it looks like I've been crying. They have a new diagnosis. I'm not crying because of they're like, what's wrong with my nurse? So it was hard. That was hard. It was hard to do that. It was hard to just keep my eyes open. It was hard because of the nausea, because you have double vision. You don't know where you're stepping. Sometimes I was kind of leaning towards the wall, thinking, well, the wall's straight, so I know that if I'm by the wall, I'm standing straight. There were a lot of little tricks and things I used, and I stopped driving at night. So that was a hard one. I would drive if I knew where I was going, but that was about it. Yeah.
Just to give Jeannie a little shout out, she mentioned she's a night shift oncology nurse. She pulled a double shift just so she could be here this weekend, so I want to thank her for that.
Well, I slept, so that's good.
So question, how did you finally find the right doctor, and what changed for you after that happened?
Oh, that was great. I hadn't been treated for thyroid eye disease. I knew I had it. I had gone to my neuro-ophthalmologist. She diagnosed me. She said, I just need you to chill out. You're hyperthyroid, take your methimazole. I need you to chill out. Which is not what you want to do when your eyes are going. I felt my vision going. I felt disfigured. That was really hard. Sorry, what was the initial question?
Just how did you finally find the right
Right.
doctor, and what
So
changed?
I looked online. You're not supposed to Google this. I know, but I did. I thought thyroid and eye, and I Googled, and Dr. Douglas was the first name that came up, and I had asked her I said, do you know a Dr. Douglas? She says, yes, I've sent some people to him, but you're not the worst case I've seen. I don't know if anybody else has heard that, but that is not something any patient wants to hear, because that is not my goal, right? That's not the bar I'm setting, is to be the worst case that doctor's seen before I get treatment. So I said, okay, well, so you don't think I should? I really don't think you just need to chill out. So I chilled out for about a month and a half. And then I was done chilling out, and I made a call to Dr. Douglas, and his office was great, and they said, come on in. And I had an appointment, but I wish I'd done it sooner. My advice would be get help as soon as you can.
Thank you. Now, in terms of navigating the financial aspects of the disease, because I know you've had multiple courses of treatment, if you could just share some of your experience with that, I think that'd be really helpful for the audience.
Well, it is a really big chunk of this disease, because it is an extensive treatment, but Karen has been absolutely pivotal in that. She's essential, and this person right here has fought and fought and fought. Thank you, because not a lot of people do that. You've done such a wonderful job. So she just keeps going. I mean, like she said, she goes up the lane and just keeps going and hammering at it. And that's what you have to do. And I think that we all, as healthcare providers and as patients, need to require that from our healthcare workers, or any healthcare worker, any healthcare provider, and ourselves. So there's some sort of self-responsibility, but there's also the responsibility for healthcare providers to have that in them to advocate for their patients and for their patient care. So thank you. Thank you. She's done such a great job.
I think that's such an important point you bring up, is making sure that you're surrounded by a team that you know is really going to advocate for you.
Yes.
How empowering that is, but how important that is to know that you're with a team that is aligned with your interests and making sure you get the treatment that you need.
I think so too.
Now, what would you tell someone who's just been diagnosed and feeling really overwhelmed and potentially hopeless about treatment options or how they're going to get back to feeling like themselves?
I think that's a really normal feeling. And like I said, I would try to find a healthcare provider that actually is in line with your goals. Sometimes we have to change providers, but that would be the advice I give. As soon as you notice something, as soon as you have a diagnosis, please go and seek treatment. Treatment for the symptoms, treatment for the disease, so that everything can improve as soon as possible.
What is the overall impact that having, we were talking about this before the session started a little bit, but what is the overall impact that thyroid eye disease has had in your daily life, and what would you want patients to know that are listening today?
I mean, it was a huge impact. It really puts people in a space within themselves. They kind of become reclusive, I feel like. You stop saying yes to invitations, you stop taking pictures with family, you stop doing parties and going to places and volunteering and all those things that make you you. They stop happening. Work, anything, all social things. I just think that it's important to get back to those things, and you will, but it takes some time. You just have to be surrounded by people, that care about you.
Thank you so much, Jamie, for your perspective and your thoughts, and for your time, and for everyone on the panel today, and for everyone in the audience for taking your Saturday morning to be with us. And we really, really appreciate it, and hope that this has been helpful. We'd love to take, I know we ran a little over, but we'd love to take some time to answer any questions you may have. So if you have any, feel free to ask anyone up here.
If anybody has any questions about treatment or
I have
absolutely.
several questions for several of you. I hope I don't dominate, but is it true that the common denominator is that you have hyperthyroidism and then you get it?
You might have to keep the question just into
Oh,
the microphone.
I'm sorry.
That's okay. That's all right.
Is the common denominator for this TED that you have hyperthyroidism, or is it possible that you don't have that, but you can still develop it?
So I think the common denominator is that you have an autoimmune disease. Your immune system is tricked into thinking that part of your body is a germ, and it makes an antibody to try and kill that germ. And the two primary targets are the thyroid hormone receptor. In most cases, probably 90%, it makes that person hyperthyroid. But sometimes we can see other autoimmune thyroid disorders, such as Hashimoto's disease. And at the same time your immune system is angry at that tissue, it's also targeting another receptor that's found in the tissues around your eye. And so these are kind of innocent bystanders of an angry immune system. And that's the common element. We see patients that have no thyroid disease at all, who have the autoimmune component targeting the eye. Most of the time, we see patients with Graves' disease, but we can see other variations as well. Hypo, hyper, normal thyroid, And I think the other thing too, the thyroid eye disease component can happen at the very beginning or at the very end. It can happen at any stage of this autoimmune experience too. Most of the time, patients come with Graves' disease, and most of the time, soon thereafter, they're showing up with their TED at that time. Anything that you'd like to add, Dr. Douglas?
No, I think that summarizes it well. And one observation that we had from COVID, both was the COVID and COVID vaccine, that amplified the immune system, as I saw a lot of reactivations and new cases. So it just kind of amplifies that this is an immune system attack problem. It's not a hyperthyroidism problem. This is an immune system attack problem. And anything that changes that or amplifies that can alter this autoimmune disease and others.
So you sort of answered my next question, I think, but have you seen more cases of this in the last so many years?
Yes, it was a spike during COVID, but all autoimmune diseases had a spike during that time. In general, the cases that I see here on the West Coast, West Side, the country, are much less severe than the cases I saw in around the Michigan and Midwest area. And I think a lot of that is from smoking, some underlying health effects. And so I do think that there's a huge geographic variation. There's a huge variation that we still don't quite understand beyond smoking, dietary, etc. So I do see probably more cases, but my cases, even compared to my colleagues around, tend to be a little less severe than some other pockets, and that's been shown even worldwide. So I think we're still understanding what influences when you see this disease and how often you see it.
If I could add, I think as well, with the advent of these new treatments, we are, as clinicians, less dismissive of symptoms of patients as well, because we do have a viable non-surgical treatment to offer now. So I think we're seeing more cases now because I think we look a little harder, and knowing that, hey, we have something that we can do this. Why would you work really hard to make a diagnosis that you can't do anything about? At least that's coming from the endocrinology perspective. So I think we as endocrinologists look a little more diligently, and we are more prone to take symptoms that we at one time may have been dismissive of a little more seriously.
Is there a certain age category? You said more women than men get it, but is there a certain age category that you find is like the sweet spot?
I'll let you answer. So it's very uncommon in pre-adolescence. So exceptionally rare. I've treated a couple of patients about 10 years old or so, but that's in my career. So very uncommon at the young age or pediatric. According to studies, there's a spike right around 35 to 50, and then a later spike in probably more around 55 to 75. Those are broad ranges though. I do see that my patients who are over 60, etc., and even higher, they have seemingly more severe disease when they get it for the first time. My patients who are younger tend to have a much more bulgy but less vision-threatening form of this disease if they're in their 30s. Those are broad things, but they've held true.
I would agree with that.
Any other questions from the audience? Oh, thanks.
I'm going to ask this because I'm one of your older patients, I think. and I wonder if I truly am. I mean, how old have patients been who you have treated?
So I've treated up to 95.
Thank you.
But anyone over 65, and I think we've had this discussion, I worry a lot about side effects of surgery, side effects of drug. Everything is harder. and more worrisome and more fragile. So there's no doubt about that.
Well, so far, I mean, I'm just feeling really good. And some of the things that you said, I don't really feel too limited. Because the only thing I've given up is a 5-mile walk every day because I don't trust where things are. But I'm traveling, I'm still very social, and I don't feel bad. Even when I had hypothyroidism, that turned to hyperthyroidism, and I read about all the kind of symptoms you have, how you feel. I never really felt them, like being tired or being anxious. So I don't know what to make of it, but I'm all for doing this treatment, believe me.
I know you were
Thank
skeptical too.
And I thank you.
I think we have a question back there. Well,
Thank you. I have a question for Dr. Douglas. Where do the patients go to get the infusions with you? And where are the Thrive locations located in Nevada? And also important for me is, what insurance plans are you in network with in the state of Nevada?
Sure. I'll let Karen answer the insurance question. So the infusions, even I can put in an IV. So the infusions, it's not so much like where you get the infusion itself. It's all about the follow-up. There are several key things and we do all the infusions in our office. I'm there, and we have a whole staff. Our nurse practitioner has done more infusions than anyone in the world, and she's been with us for many years. So the key is what has to be done as far as your follow-up. And that is audiology at baseline, audiology approximately every other visit or so, sometime. And then if we do note any changes or anything that's going wrong, we can extend that treatment. We can alter your treatment. We can do various things, including checking your hemoglobin A1C before you start, blood glucose as you're going, referrals to great partners like Dr. Litchfield if there's anything that's going sideways. So those are the things and then we also do vitamin infusions, et cetera, to overcome some of the more, this tiredness, et cetera. So it's more about making sure that journey through the infusion is easy and that you don't have building side effects. The problems with Tepezza side effects is that they build. They don't happen the first dose, even the second dose, but then they start to stack on one on top of another. And then sometimes you just need a little break. And sometimes you just need to let some of those side effects and some of that drug come away and follow that. And that's the decision point that's hopefully that I think that we offer from that standpoint.
Thank you.
And then Karen.
As far as insurances go, we look at every single insurance policy, even if it's an HMO. Do we contract with every insurance? No, but we vet every single insurance. Most insurances still to this day will allow all patients to come to us. It's only an HMO that we have a little bit of difficulty with, but most policies still have an in or out of network benefit. And so we've had a lot of success at getting all insurances to be pushed through with us. So we want the opportunity to at least vet every single insurance. Whether we're contracted or not is another story, but we scrutinize every single insurance and look at the policy to see if it's a match for our office.
Can you answer the question about the locations as well?
Oh, sure. And usually there's not additional out of pocket with the copay assist or anything else like that. So this is one of the times where that doesn't financially hurt you. Our current office is in Summerlin, Nevada, and then we also have several offices in California and other places in the country, but Summerlin, Nevada.
Yeah, I was just concerned about the travel because I know you guys say you have foundation support, so I know it's hard for people to travel sometimes, and it's hard to find good providers out here, so sometimes people do have to end up going into California or Arizona, and it could be expensive, but so that's why I was looking through your brochure and I was saw the foundation assistance with travel and all the things, so that caught my eye.
Yeah, we do search for that as well, as far as foundation support to help with travel. So that, Our goal really is that the burden of the out-of-pocket cost is very minimal. So as I'm looking at insurances, I'm looking at, okay, what are your travel requirements to get to our office? And we've got several foundations programs that do help with that out-of-pocket, as well as looking at that benefit. You know, a lot of times patients fare better, like Dr. Douglas was saying, when they do go out of network, because we're not contractually obligated to bill you for your share. And so it's really helpful for our patients. So that's what I'm doing when I'm screening the benefit, is looking for what's the patient out-of-pocket cost, who's gonna cover it. And so most patients don't have any out-of-pocket to come to us because we are not contractually bound by any insurances.
So it's interesting you say about the barriers. So about 10 years ago, we started a foundation when I was at the University of Michigan to help to overcome the barriers of transportation and patient costs. That was funded by a patient of mine, and we've now restarted a foundation here that we're just called Eye to Eye, and we're going to try to do one of the goals will be to do that, is to not necessarily help with the cost of treatment. It's probably a little hefty from the foundation, but to help with the things that create barriers to treatment, getting an Uber, getting childcare, things that are small but very significant impediments to trying to do that. And so hopefully we'll be able to offer some more updates on that very soon too.
That's great.
Thank you. We have a couple questions from our virtual audience. One is, have either of you seen any patients whose nervous system or stress response, for example, anxiety level, has been impacted by Tepezza? And if so, how did you handle it?
I'm not sure that I've seen, that I can think of any issues with that. I'll maybe see if Dr. Douglas has any experience there.
No, I can't recall anything like that. I have a lot of very routine discussions with my colleagues. I know that there's been a patient who's reported a little bit more mental haziness that when they were on Tepezza that went away afterwards. Anxiety and such, honestly, I've almost uniformly noticed that that's gotten better, because as the disease gets a little better with the treatment, patients will notice that. So I've not seen that, and I've not heard of any case reports like that. I might think of, is there an alternative cause going on here, and dig a little deeper into that.
Yeah, and obviously anxiety can be a big part of untreated Graves' disease or untreated hyperthyroidism, and so usually that's settled down first though. So if that is an issue, then it would be important to make sure that your thyroid chemistry is where it needs to be.
Great, thank you. A question for Dr. Douglas. You had briefly mentioned about vitamin infusions during Tepezza treatment, and I'll preface that with, at Thrive Health, every patient who comes in and is infused with teprotumumab gets infusion with IV hydration with vitamins. The question was, why do you feel that vitamin infusions help patients who are receiving Tepezza?
Yeah, so this is something, it's just an idea that I had when we were infusing Tepezza patients, that they get muscle spasms, and there's often debilitating muscle spasms. We did this when we first noted the trials. In fact, there was one patient in the trial 5 years ago that actually had to pull out of the trial because they had muscle spasms near their diaphragmatic area. It was quite painful. But people usually get like Charlie horses. And it's usually, usually associated with the magnesium, seemed to help a little bit. And so got the idea that, well, if you have some vitamin, infusions, you get them post-hangover, you get these other things. And even in other fields, patients seem to do very, very well. So we created a system where they got a lot of magnesium, zinc, which is often low in thyroid, vitamin C, some B vitamins, etc. And we offered it to patients with a little bit of hydration. And all of a sudden we did a little mini study that post their treatment, almost all these little nuisance symptoms kind of went. They weren't fatigued the next day. They didn't seem to have the muscle spasms nearly as bad. And patients really loved it. And we used to charge for it because it costs money to mix all of this. But then it was just so, patients liked it so much. I remember you're getting some, Gene.
Yeah, I was gonna say something about that.
Yeah, that we just decided to give it to everyone and just, absorb the cost of it because it just seemed to help as much. So I can't say that, it was mostly just kind of a little art of medicine and trying stuff.
I will speak to that because I had infusions without the hydration and the vitamins, and then I had infusion with, and I felt remarkably better after the infusion, post-infusion. For that day, the day after, there was a marked difference. So it really does help, and I really didn't think it was going to help. I was like, no, I don't need that. And then, no, you should try it. So I did. It was much better. So I do definitely appreciate that facet of it.
And a little bit of mineral water will also help. Good hydration that night. So there are some basic things, but anecdotally they've worked very well. And usually patients feel pretty good, and you're there anyway for just monitoring. So it seems like
Thank you. I have a couple questions that I'm going to ask. We talked a lot about how in the last 5 years the treatment landscape and options have changed with this new drug, Tepezza. But historically, and I'm sure many of you have experienced, and even Jeannie was mentioning that her doctor said you're not bad enough to require treatment. Maybe from the perspective of that provider, but from a patient perspective, you definitely want treatment. You don't, you want to get back to yourself. But up until 2020, we had limited tools, and from a oculoplastic perspective, the biggest tool you had was really surgery, but you had to wait for a patient to get stabilized before you could really operate on them, and that could take 2-3 years. With the advent of Tepezza, we now have treatment options, and we want to be able to treat patients as quickly as we can if we know they're going to benefit. But the question I'd like to pose is, with now having more options, Tepezza, surgery, with the options that still exist, steroids and radiation, what is your decision-making tree for when you decide a patient would be a candidate for Tepezza versus surgery, or potentially require those treatments sequentially?
I would definitely agree that my primary goal is my first objective is to stabilize the thyroid. But knowing that we do have tools that we did not have 6 or 7 years ago, we are, at least in my practice, are more proactive involving oculoplastic surgeons in the treatment paradigm. So we involve them at an earlier stage. Not every patient is going to need Tepezza, and in many cases we will see things settle down and they won't need that. But I think, I guess having been guilty is probably the wrong word, but guilty, for lack of a better word, of having patients live with their symptoms when I didn't have much else to offer, knowing that we do have something to offer. I involve Dr. Douglas and colleagues of his like him in that space at a much earlier stage. And the hope, of course, would be that conservative things to help them live with their symptoms and diminish those symptoms if possible, even without Tepezza, will help as I stabilize their thyroid. And if not, we don't need patients to wait. This is a progressive disease. If it is left unchecked for long enough, a problem that's relatively easier to treat in those early days becomes a chronic disease that is much more difficult to treat and responds less well to those treatments. So I think it is important for the endocrinologist to get after it and stabilize the thyroid as quickly as they can, but to not wait too long to involve other colleagues that will provide a different element of the care that we just can't do in my office. And so that's been my take, and I think in general that has been, thankfully, for the patients, at least from their perspective, they don't have to wait. They don't have to suffer. They don't have to become the worst case in town or in practice to suddenly meet a threshold that would require referral to another doctor.
Yeah, and I guess I'll just comment with an example maybe of Tepezza versus surgery. And again, a lot of times the answer is both. But for example, if a patient's younger and they have just bulgy eyes, I demonstrated in one of my surgical examples, their eyes are just bulgy, and if I give them Tepezza, maybe it'll pull their eyes back a little bit. But they don't have any double vision, they're young, I can do this surgery in an hour and a half on both sides, and they'll have an amazing result, and that'll be it. I'll often tell them, you know what, I think you're just better off getting surgery, and I think you're going to be better off in this way. The risk of double vision is less than 1%. I think we can move forward in a great way. If a patient has double vision, very significant inflammation, or problems that are just not going to be easy for me to handle with surgery, meaning that general anesthesia is going to be a problem. A 2-hour general anesthesia could be risky for them. They might or that my surgery is not going to fix, then I'm much more likely, let's go with Tepezza and then try to fix what we can with surgery later on. But double vision, inflammation is a big pusher for me into more of a Tepezza range because I can't fix that very easily with surgery. I can't make someone happy with surgery as I can with a medication that can help to reverse the disease. So a lot of times, again, it's individual and you're pushing one, you're pushing the risk and the benefit of both one way or the other.
Thank you. My next question is, being a relatively new therapy that we've only had for 5 years, and you being a person that's probably treated more patients than anyone in the world, as we've had more experience and have more of an understanding of the potential side effects, which is something that is definitely on patients' mind as they're starting a new therapy, can you speak to some of the potential side effects of Tepezza, how we monitor them, how we mitigate them, and what patients you may actually caution against receiving Tepezza or people who may not be candidates?
Yeah, so I'll go through these pretty quickly. So it's a new medicine, but it's not a new medicine. So this medicine came off the shelf of a drug company because it failed in another treatment. There was a whole push about 15 years ago for these types of medicines that inhibit this receptor in cancer, breast cancer, all kind of cancers. They all failed, unfortunately. But this type of medicine was perfect for thyroid eye disease, and that's how it was repurposed. It wasn't created from new, that's why it was repurposed. That's how it was done so quickly. So we actually have a ton of safety data from these patients. So we know that whatever we're seeing now or during the course of the therapy is likely all the side effects you're going to get. So there's not going to be something that's going to pop up 10 years from now from what we know and what we've seen, because we do have a long history in how this works. But the major things that are really, really important are hearing. You have to have a baseline hearing, you have to be monitored for hearing, and extending treatments, etc., can really make a big difference in preventing some of those side effects from occurring. They don't occur in everyone, but they do occur in 30% of people with already a predisposition to it. If you don't have baseline hearing loss, you're going to be fine. The other thing is you can't get pregnant. It's a precaution, but this is a growth inhibitor, so no pregnancy during the course or 6 months after. The menstrual cycles will be altered. It wasn't initially reported on label because the funny thing about the FDA is, just at-risk population, but their menstrual cycles will be abnormal, but they will return back to normal. The muscle spasms, skin thinning, little hair loss, that will all return back to normal, where it has typically after 3 months after stopping of therapy. The hyperglycemia occurs in 10% of patients, typically pretty well controlled, at least compared to steroids, but still has to be monitored. I've had patients who've gone into the 300s with their blood glucose just because they were probably, frankly, they weren't diagnosed. And they kind of had high hemoglobin A1Cs, but they can drift that way. So those are the major things to watch out for and to monitor.
Thank you. That was the last question I had, and I think we're probably going to wrap things up. We want to again thank the panel for your time, your sharing your expertise and experience, and to the audience for spending your Saturday morning with us. The panel will be here, so if you want to mingle and ask questions, we're happy to answer any questions you may have, and we'd love any feedback to make this program better. But again, thank you all, and hope you all have a wonderful day.